All right, hello everyone, and welcome to tonight's webinar. I'm just waiting to make sure that everyone comes in from the waiting room. All right, excellent. It looks like quite a few people are able to join. So welcome to tonight's webinar, which is 5 ways micronutrient testing and IV nutrition therapy can achieve proactive wellness. And my name is Emily Holst, and I'm the marketing coordinator over at Vibrant Labs. And we are so excited to have Dr. Christopher Davis, who is the Chief Medical Officer of Liquivida Lounge, join us tonight for this great webinar. So a few things before we go ahead and start the webinar. First things first, we will be recording tonight's presentation. So if you are a provider with Vibrant Labs, then you should receive an email in about 3 to 5 business days with the recording. And if not, then it'll also be up on our YouTube channel as well, so you can find it on our social media. And now let me go ahead and tell you all a little bit about Dr. Davis before he begins. Let's see. All right, so Dr. Christopher Davis is a triple board certified integrative interventional cardiologist with a passion for educating and empowering individuals to take control of their own health by teaching simple lifestyle changes that have been overlooked by our medical establishment for years. He completed his undergraduate education at Duke University and medical school at Eastern Virginia Medical School. He then completed his internal medicine residency at Johns Hopkins University-Sinai Hospital and went on to serve as chief medical resident at Johns Hopkins. And then from there, he gained quite a bit of education in functional medicine. And today, Dr. Davis serves as the medical director at Hippocrates Health Institute, a world-renowned health wellness spa in West Palm Beach, Florida, as well as chief medical officer of Liquivida Lounge, which is an industry-leading IV nutrient therapy corporation. And Dr. Davis takes great pride in the compassionate care he provides to his clients and their families. So Dr. Davis, again, we are thrilled to partner with you on this webinar, and I'll let you go ahead and take it from here.
Wonderful, thank you, thank you. Well, thank everybody for joining today. Let me see if we can get everything set up here and showing. So let me share my screen.
Perfect.
All right, can you guys see my screen now?
Yes, we can.
You'll hear me. All right. Well, again, thanks everybody for joining us. I'm super excited to be here to talk to you all tonight about Vibrant's micronutrient panel. Vibrant has a whole host of testing that I utilize. But just a little bit about myself. Again, I'm an interventional cardiologist, and I'm sure most people will be asking, I get asked all the time, you know, you're an interventional cardiologist. Why are you doing micronutrient testing and gut testing and all this other integrative medicine, you know, studies and practice? And at the end of the day, it kind of boils down to, I realized that we had a problem with our healthcare system, and I had to try to figure out what I needed to do to try to be a part of the solution. And so what I hope to do tonight is not only talk to you all about the micronutrient test, how we can use it, but I really want to empower you all to really take a step forward and make a statement about really changing healthcare as we know it. I mean, all of the physicians and PAs are out there. You know, we all went through a traditional education and it's fantastic, I'm sure, but there's some things that we definitely need to step up to the plate and say, hey, look, there's some other things we need to do to truly allow our patients to optimize their health. Now, my road really started with this book here called Undoctored. About 4 years ago, I read this book by William Davis that is Undoctored, Why Healthcare Has Failed You and How You Can Become Smarter Than Your Doctor. And it was really written for lay people, but what he wrote about in this book, particularly with cardiologists, he's a cardiologist, he's the guy who wrote Wheat Belly. What he talks about in this book, I mean, he talks about him as a cardiologist, and you would get a stress test and an echo every single year, and stress test is abnormal. We go and we put a stent in, and you do it over and you do it over and over and over again. And as I read this book, I thought to myself, this is exactly what I'm doing. I'm seeing 40 patients a day, and we just keep doing the same thing over and over again. Take your statin, take your beta blocker. But at the end of the day, you know, healthcare is a system created to deliver the greatest revenue generating products and procedures to address the illness, but not provide health. And that statement really stood out to me. And to this day, I still think that that's kind of where we are with healthcare. The next slide, you know, as I kind of made this whole transition, you can see this was in April of 2018. I walked in, this is a guy that I cathed on the day prior to this, and he ended up needing a bypass surgery. So he went through his bypass surgery, and I walk into his room post-op, and this is what he's eating. This is the tray that comes into the hospital. And literally at that point, I had already started to kind of say, man, what are we doing? I mean, we're kind of missing the forest for the trees here, is truly as to how to get our clients or patients better. And so I took this picture way back then because I knew at that point that I was going to be doing something different and I was going to be practicing different. I didn't know when I was going to use this picture, but it's for times like these when I'm talking to other physicians in particular that I really want you guys just to say, you know, I mean, if you're questioning what you're doing, don't be afraid to really step out there and say, okay, there's more to what I'm doing. There's more to the practice of medicine than kind of some of the things that we've been doing before. You know, there's an old saying here, and I think we've all seen this by Albert Einstein: insanity is doing the same thing over and over again and expecting a different result. So going into my cardiology practice and seeing 40 to 50 patients a day, spending 5 to 6 minutes with them, and expecting them to make, dramatic results and get, and really truly get better. I mean, that was just unrealistic for me. And so I realized at that point, okay, it was time to do something different. One of my pictures here is missing, but there was a book written in 1979 called Rockefeller Medicine Men. And that was another book that really gave me some inspiration to not just kind of follow the crowd on everything we've been told. And this is the introduction to that book. This was written in 1979. I'm not going to read the whole thing, and I can make this slide presentation available, but this book talks about, you know, the crisis in today's healthcare system. And again, remember, this is in 1979, and basically talk about how the system is set up out of economic and social interests. And at the end of the day, this history emerged a medical system of poorly served society's health needs. So I'm going to come down off this, off of my social commentary very soon, but I want all of you really to take heed to this. And at the end of the day, what I want you to do is really, these are my 2 daughters, okay? And this is what we have in each of their rooms: stand in your truth. And I think that all of us need to kind of realize that, you know, particularly, and again, I don't want to become too politically charged here, but I think we all need to stand in our truth. And when we know something is not right, you know, there's no one person that's going to be able to fix an entire system. But I think if we all are bold enough to speak out and speak together, then we can make a difference. Now, with all that being said, let's talk about micronutrients. Let's talk about the fun stuff you guys want to hear tonight. I think the micronutrient panel is a pivotal part of my evaluation of every patient that comes into my office. Tonight, we're going to talk about micronutrient testing and understanding how it can significantly improve your patient outcomes, understanding the role of micronutrients in mitochondrial health and longevity. We're going to talk about highlighting common conditions associated with glutathione deficiency. I think there's obviously some overlap between mitochondrial health and glutathione deficiency. I'm going to do some case presentations, and I'm going to do a few case presentations on cardiovascular health, because obviously that's my baby. Although I do a lot of other things, I mean, I think that we do a poor job of preventative cardiovascular medicine, and I'm going to show you why tonight, and I want to show you the role of the micronutrient test as far as helping with preventative cardiovascular medicine. And then finally, we're going to talk about understanding how intravenous and intramuscular micronutrient therapies are an important tool in health optimization. So we all know that we live in a world of chronic disease. You know, 6 in 10 of us have a chronic disease in the United States. These are all CDC data here. 4 in 10 have 2 or more of these chronic diseases: heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease. We see more and more of these neurocognitive issues these days. And at the end of the day, we're spending trillions of dollars on these chronic diseases. And really, honestly, we're coming up with more and more expensive treatments and more expensive procedures, yet we don't ever do what I call look under the hood to try to address these things. And I think a big part of looking under the hood of heart disease, of cancer, of stroke, of Alzheimer's disease is this micronutrient panel. I think we could all agree that we now know that, inflammation is the secret killer, and inflammation is linked to all of these chronic diseases. Every single one of those diseases that I just showed you are linked to inflammation. Inflammation is then tied to oxidative stress as well. So if we look here, cancer, diabetes, Parkinson's disease, chronic fatigue, Lyme disease, all of these conditions are linked to inflammation and oxidative stress. So in turn, oxidative stress, we know, and we're going to talk about this a little more in detail, that oxidative stress has a lot to do with mitochondrial dysfunction. And I think that we all, from in every one of our patients, and whatever the conditions are, I'm a firm believer now that we need to be thinking about the mitochondria in every person that comes into your office, because at the end of the day, that the mitochondrial function and mitochondrial biogenesis and how efficient the mitochondria are determine, the outcomes with all these chronic diseases determines your patient's energy levels. It determines, whether you have, diabetes. It determines these neurologic conditions. And more importantly for me, from a heart disease perspective, we know that it's very important. And so it's oftentimes hard to talk to your patients about, well, what the heck is oxidative stress? So I use this analogy here in all of my patients. When I talk about inflammation and oxidative stress, I use the analogy of a metal pipe. And as that pipe gets older and older and that rust starts to build up inside that pipe, that's oxidative stress. That's oxidation that goes on inside that pipe. And so I give them this analogy and I say, that pipe gets rusty inside, right? And what we're doing as we're aging, as we're developing this chronic disease, essentially we're getting rusty. So I asked them, do you want to continue to get rusty, or do you want to figure out how we can do something to figure out how we can remove or get rid of that rust? And so I also will then show them these pictures of the inside of a coronary artery. This is a coronary artery. And very much like this metal pipe here, as it develops this oxidative stress and rust buildup, plaque builds up on a similar principle of the oxidative stress that happens within the lumen of this vessel. So what exactly is this oxidative stress? It's an imbalance between the production and accumulation of reactive oxygen species. So what are these reactive oxygen species? These are metabolites of oxygen. As we take in oxygen, 90% of the oxygen that we use is actually utilized in the mitochondria. So we always think about the mitochondria as the powerhouses of the cell, and they do produce all of the ATP. But on the other hand, we have to realize that the majority of the reactive oxygen species are also produced in the mitochondria. So superoxide, hydrogen peroxide, the singlet oxygens, all of these are produced in the mitochondria. So what happens when we're younger and what happens when we're older? When we're younger, these mitochondria are functioning very efficiently, okay? We're taking in the nutrients that we need, we're taking in the oxygen, and we're making more of this energy, ATP, than we are of the free radicals. But as we get older, this mitochondrial function or efficiency becomes less and less and less. So this electron transport chain that occurs here in the outer membrane, inner membrane, it doesn't work as efficiently, right? And so what ends up happening is we take in less nutrients, less oxygen, and we make less energy, ATP, but we start to make more and more of these free radicals. And these free radicals then in turn cause more inflammation, and they cause more damage to all of our tissues. So what's important, I'm going to go, because here's where we're going to lead in now to the micronutrients. Why are micronutrients important? We need these nutrients and oxygen for the mitochondria to function appropriately. So here's a little depiction of some of the micronutrients that are really important in normal mitochondrial function and mitochondrial biogenesis. We talk about B vitamins, and I cannot emphasize enough the importance of all of the B vitamins, not just B12. The number of people who come to the doctor's office and they've had a B12 level checked and it was okay, or it was too low or too high. I mean, everybody has their B12 level checked, but I could probably count on one hand the number of people who showed up here and they've had B1, B2, B3, B5, even B6 levels checked. So I think it's very important as you look at this diagram here, there are multiple B vitamins. There's manganese that's important for superoxide dismutase. There's iron that's important. So there are multiple micronutrients that are super important in the whole function of this mitochondrial complex and for energy production at the end. So what are micronutrients? Micronutrients are supplied by foods and are required for normal metabolism, growth, and physical well-being. A nutritional deficiency occurs when the body doesn't absorb the food or the food doesn't provide the necessary amount of the nutrients. So I think we all also will be safe to say we know that the foods that we have today is not the food of 30 years ago or 40 years ago. The nutrient content of most of the foods that we have 20 to 30% less of magnesium and iodine and all the other micronutrients. And there are lots of studies that show that. And so part of this nutrient deficiency results around the fact that our foods are just not the same. Some of the other things are obviously toxins in our environment, the absorption of the foods with all of the people with leaky gut and abnormal microbiome. So we really have an epidemic of micronutrient deficiencies, and very few people that I see that come in and get the micronutrient panel have micronutrient amounts that are adequate, particularly when we're looking at the intracellular component, which we'll talk about in just a little bit. So the role of micronutrients, what do they do? We looked at the mitochondria just shortly ago, and so the micronutrients are very important in mitochondrial function. So they are important in producing and releasing energy, strengthening the immune system, inflammation, reducing inflammation, protecting against free radical damage. We just talked about that. Protecting against the progression and recurrence of cancer. Maintaining insulin sensitivity, really important with this whole epidemic of diabetes. Slowing down cellular aging, promoting health of all tissues, skin, bone, brain, and then lastly, maintaining healthy hormonal balance. When we think about micronutrients, we have vitamins and minerals, metabolites, fatty acids, and amino acids, and we'll talk a little bit more about those as we go through some of the cases where we look at the micronutrient panel. One of the other things that we see with micronutrient deficiencies, there are a host of symptoms, and I think a lot of times we often will overlook a lot of the symptoms that our clients or patients present with and not even think about trying to, from a nutritional perspective, what could be going on. I mean, I'll tell you, I see a lot of neurological issues. Although I'm a cardiologist, at this point, I see a lot of patients that end up coming to me with anxiety issues and depression, even patients with neurocognitive decline. And the importance of optimizing their micronutrients, I can't say enough about what I've seen when we optimize their micronutrients. For those of you who do a lot of the aesthetics, again, thinking about micronutrient deficiencies with hair issues and nails and skin, really, really important. So let's take a closer look. Now, I'm going to tell you right now, these next two slides, I'm not going to bore you with, and I think I did this sort of as a joke, but at the end of the day, it's really important. There will be a quiz on this slide and the next slide at the end of this presentation, so I want you guys to take notes. This is Vibrant's organic acids panel, okay? If you guys remember back in medical school for the physicians and PAs and stuff out there, we all learned these mnemonics for the citric acid cycle, TCA cycle, Krebs cycle, whatever you want to call it. And we learned all these different parts of the Krebs cycle. Well, the Krebs cycle is how we make ATP. At the end of the day, down at the bottom here, this is how ATP is made. But I only put this in here honestly to show you, we can always go back to this picture. And when I'm looking to try to figure out what's going on, I always go back to these diagrams because I can never remember all these steps. But what I can see is what micronutrients, what vitamins, what minerals are important along the way. And I can then try to backtrack and try to figure out where some of the issues may be. But I just want to show you how things like the vitamin A and magnesium, and again, all of the B vitamins are super important for this process to move forward efficiently. Also, I think also just as important, one of the things that I think is sorely missed these days is heavy metal toxicity and also environmental toxin. But the heavy metals, I mean, once you start to really get into heavy metals, you'll see that the number of people that I see with arsenic issues that are high. Now, they may not be toxic, it may be issues of recent exposure, but at least you can have conversations with your clients about where that arsenic exposure may be coming from, or mercury, or fluoride, well, whatever it may be. You can see here, some of these are actually marked along the cycle pathways as well. Now, this next one, I know you guys all remember this, and I know you can't see this, but what I'm going to do here is I am going to zoom in. This is for kicks and giggles. You guys remember all of this stuff here, right? Okay. What I want to do is I'm going to show some cases, and although I know that, I mean, I can't pretend to remember all this stuff, but I want to show you how just having this information at hand can really help you with your patients. I mean, there is a lot of information on here, but I can tell you when you go back in here and you kind of talk to your patients about what's going on, you look at their micronutrient issues, you look at their genetics, I can promise you, you will have results like you've never seen. You won't need sleeping medicines. You won't need medicines for anxiety and depression because it's all in here. Okay. So with that being said, we'll save that and we'll go through that a little bit further as I present some cases. So extracellular versus intracellular micronutrients. I think this is really important, and you're going to see this in some of the case presentations as well. I think what we're all used to, for the most part, when we go to Quest and we send we send for B12 or whatever, we're going to get extracellular concentrations of whatever the micronutrient we're looking at. Okay. What's important is that when we are looking at micronutrients, vitamins, minerals, we need to know how much of that is getting inside of the cell as well, because actually where that micronutrient is going to be active is inside of the cell. And so one of the benefits of the Vibrant panel, obviously, is that we're going to be looking at extracellular micronutrients and the intracellular concentration of those nutrients. So when you're looking at the extracellular micronutrients, we're looking at static measures, kind of the short term over the last few days of this whatever particular micronutrient that is. So it really is looking at that person's diet over the relatively narrow time frame. Whereas when we look inside of the white blood cells, the intracellular amounts of the micronutrient, then we're looking at over the course of 30 days or so. So a much longer time that we're looking at whatever that micronutrient is. And there's quite a host of things that can influence the intracellular uptake of the micronutrients. Some of the things that are really important: genetics, aging, lifestyle, chronic illness, medications, which we'll talk about in just a little bit. Intracellular testing takes all of the above factors into consideration and to identify your cellular nutrient absorption status. And so that's really important, and we'll spend a little bit more time on that when we get through to some of the cases as well. Factors affecting exogenous nutrients and absorption. So diet, so what you're eating obviously is going to affect, what your nutrient content is like. Medications, biotoxins, so with all the biofilms and heavy metals and mycotoxins, they're going to affect absorption of the nutrients. Stress has a big role in the nutrient absorption as well. Bacterial imbalance, SIBO, other intestinal permeability issues, parasites. So these are all factors that are going to influence your nutrient concentrations. I just wanted to mention really quickly, because this oftentimes comes up, there's so many different diets out there, and your patients will come in and they're on a paleo diet or a ketogenic diet. Just keep in mind that there are certain micronutrient deficiencies we should be thinking of when patients are on a restrictive diet. When they're on a low carb or ketogenic diet, we should be thinking about things like calcium, copper, magnesium, B5, pantothenic acid, vitamin E deficiencies. Same thing when people are eating a gluten-free diet, which I'm sure most of you are recommending gluten-free diets. We need to be thinking about these deficiencies here, because most of those foods that are wheat-based foods are fortified with these. So we need to make sure that our patients are getting these micronutrients, calcium, iron, magnesium, zinc, from other sources as well. Another important thing Vibrant has available for all of you, and I'm not going to spend a lot of time on this, they have this 3-page PDF of medications that interfere with nutrient absorption. And I think it's really important to realize that I circled a couple of these because they're kind of seen throughout. When patients are on tricyclic antidepressants, oral contraceptives, NSAIDs, and proton pump inhibitors, invariably there are a lot of micronutrient deficiencies. So at your leisure, I would advise all of you guys, or recommend you kind of look at this particular document, because I think it's very helpful in trying to understand, why patients may have some of the micronutrient deficiencies. So here's the first case. This is a lady who's a 54-year-old who has a history of Hashimoto's thyroiditis, who presented for the initial evaluation. And her main concern was that of severe anxiety, decreased energy levels. She also complained of some orthostatic dizziness, palpitations. It had been going on for the past several months. She also had a lot of issues with insomnia. She had recently seen another doctor who had given her a prescription for Xanax and Trazodone, and she showed up in my office just trying to figure out, okay, what's going on? This is not the answer to this. I'm looking for some other alternatives. So this is a summary of her micronutrient panel. Okay, we're going to dive a little bit more into this. So Vibrant's micronutrient panel, for those of you who have not looked at the panel, they present the data in many different formats. They have a summary sheet. They have it in just looking at the ranges and what the values are. And then they have the part that I like to look at, I'm going to show you next. They have kind of where the levels are high and they're low, and they show intracellular and extracellular. And I'm going to move into that shortly. But what we see on her panel, I want to make mention of a couple things. Okay, so what we see here is her folate is low, right? Her zinc and selenium are low. And so just looking at her presenting history, a couple of things here, right? We know that thyroid issues or thyroiditis, your thyroid gland needs selenium and zinc to produce the appropriate amount of thyroid, or even for that T4 to T3 conversion, right? So just off the bat, I know that, okay, if we replete her zinc and selenium, we're going to probably help her thyroid function. But more importantly, I see that folate's low, and I know that folate is a really important part of a cycle called methylation, right? Now, methylation is a process that certainly we don't have enough time to get into methylation tonight, but I can tell you that it's super important in many different processes. I think you guys know that it's important in DNA repair, it's important in how we age, it's important in hormone metabolism, it's important in neurotransmitter metabolism. But in a lady who comes in with anxiety issues and heart racing, I am concerned about methylation when her folate levels are low. So I'm kind of thinking along those lines as we kind of move into, okay, what else are we going to do for her? So one of the things I think that's super interesting here is if you look at her folate level, and this is why Vibrant is so critical when you have both serum and red blood cell or intracellular levels of your micronutrients. Her folate levels are off the chart here. They're greater than 20. Yet the intracellular red blood cell folate levels are really, really low. So for some reason, what does that tell me? That tells me she's not getting the folate inside of the cells for whatever reason, whether it's a cell membrane issue, whatever the issue is, she's not getting folate inside of her cells to function appropriately. So now I'm starting to really think still, okay, this may be related to her anxiety issues due to undermethylation. Back to her selenium and zinc issues again. Her intracellular levels are quite low, whereas the extracellular levels are okay for the selenium and a little on the lower side for zinc. But what that tells me is we could give her a little bit more of both of these to hopefully try to get the intracellular content up. For folate, though, there's no more, I can't give her more folate because it doesn't look like I'm really going to push it inside of the cell. So I had to think about, okay, what else can we do, okay, to potentially help with, if this is an undermethylation issue, what else can we do? So we're gonna go to that in just a second. My next test, I do a lot of genetics, obviously, so I was already thinking about methylation. And so we did genetics on her, and she turns out to be a homozygous variant for the MTHFR 677T. So she has a variant where she is not going to methylate like, other people. That's probably about a 70% reduction in her methylation capacity just based on that 677T variant. On top of that, she was a MET variant of COMT. And if you look here, COMT is very important for methylation as well. So now I have a folate level that's in the toilet. I have a MTHFR 677T homozygous variant and COMT variant. So now I'm really thinking, okay, this lady's anxiety is probably really driven by undermethylation. So I want to go back to this picture again here because Remember, I told you, sorry. Remember we said that, okay, I use this to kind of help guide me sometimes. I know it's a bit much, but at the end of the day, if this person is not methylating well, okay, so she doesn't have enough folate to take her through the methylation cycle and make S-adenomethionine, SAMe. This is the universal methyl donor, right? This is how we methylate most substances. This is how methylation occurs. Well, if she can't produce SAMe to go down and methylate methylate norepinephrine, okay, to be broken down, then she's going to start to build up norepinephrine because she can't break it down, on top of the fact that she had this COMT variant and can't break it down. So what's going to happen? Anytime she gets anxious, the norepinephrine levels, epinephrine levels are going to be revved up, and she's going to be incredibly anxious, incredibly anxious. So I can't give her more folate. So what did I do? I gave her SAMe as a supplement. And after giving her SAMe, the anxiety over the course of about a month and a half, she was a different person. What also happened when doing that is that SAMe is also really important in actually turning serotonin into melatonin. And what other problem did she have? She couldn't sleep. So now she's sleeping much better. I didn't do anything else, but we just helped her go through these processes like she should. Just then now you can see, I hope you guys can see how, although this thing looks overwhelming, when you look at the micronutrient panel and you can put these pieces together, this is what I call looking under the hood, and we all have the ability to do that. And so this lady, she is as happy as a clam now, taking her SAMe, not anxious anymore. She's sleeping and doing quite well. So switch gears a little bit. Let's talk about glutathione. We talked about all the chronic diseases out there, and we talked about reactive oxygen species and how that causes us to get rusty. So what is that natural rust buster out there? And so glutathione is Mother Nature's master antioxidant. This is the molecule, although there are lots of them out there, CoQ10, alpha lipoic acid, vitamin C, these are all antioxidants. But glutathione is Mother Nature's master antioxidant. And it consists of a tripeptide of cysteine, glycine, and glutamic acid. It's found in high concentrations in almost every cell. It's same concentration as potassium, glucose, and cholesterol. So very, very high concentrations of glutathione in the cells are needed. And as we get older, the glutathione decreases with age about 1% per year. So why do we need more and more glutathione? I mean, obviously, we know we live in a toxic world, right? We live in a world with pollution and other environmental toxins and plastics and other persistent organic pollutants and what we eat. And so all of these things, we need our body and detox systems to be optimized. And we need that glutathione to be optimized at all times if we're going to be healthy and we're going to age gracefully. So glutathione is the cell's primary defense against free radicals. It functions both as an antioxidant and a detoxifying agent. The most effective way of actually increasing the level of glutathione is actually giving it intravenously. So diseases that are associated with low glutathione, you can see here, there are a host of these because again, what happens is if you have increased oxidative stress and you don't have enough glutathione to counter the oxidative stress, then all of these conditions can revolve around that. One of the things that we see a lot of is neurodegenerative disorders like Alzheimer's and Parkinson's disease that are associated with glutathione depletion. Also pulmonary disease. With respect to the neurocognitive issues, we know that there's 50% less glutathione in a substantial nigra of Parkinson's patients. And some of the protocols that are out there, glutathione, 600 milligrams IV twice a day for 30 days. I think that this was one protocol that another practitioner used. I mean, I personally have used, I do the glutathione, the 2,000 milligrams just once every other week on a lot of my clients, and they still have done quite well. In fact, I think my next slide, I want to actually show you, how, when you have a client that, I want to show you the next picture I want to show you guys, and I need to get out, this link doesn't work, so just give me 1 second, because I want you guys to see this.
We're about to do your
tremors are at the moment, and if you try and do anything, like hold your hands out straight, and you can use both arms. The IV won't get hurt. More in the left side than the right, typically. Okay, and how about if you touch your nose? All right, and you said buttoning your shirt gets real.
I have difficulty trying to button my shirt. I mean, this is what happens.
Okay. All right. Well, this infusion will just take about 20 minutes, and then we'll check you. Okay, here's our after photo shoot. How are you feeling, Mr. Rhymes?
Feel fine.
Feel fine? How's your tremors? I think that's a huge difference. What do you think?
It's a major difference.
Great. How about we do the touch in the nose and the
See, the right one,
button?
there's really nothing there.
That was amazingly steady. How about your buttons? You couldn't even get it unbuttoned before, could you?
No.
All right. Well, thank you, sir.
So that was the first glutathione drip that I did. This was kind of my initial experience as I started to kind of go into this integrative medicine world. And I tell you, this was an amazing experience. It almost was too good to be true. I had read a bunch of Dr. Perlmutter's work and said, let me just try this. And lo and behold, that's the experience that we had. That was trial number one. Since that time, we've had many more successes like that. So how do we increase our glutathione levels? Decreasing the need by decreasing the toxic load, decreasing the persistent organic pollutants by not consuming conventionally grown food. So eating organic, really important. Limiting the alcohol consumption, taking antioxidant vitamins to decrease the oxidative stress loads, and taking alpha lipoic acid, which helps to recycle the glutathione. Routes of glutathione administration, it can be given orally, topically, intravenously, intranasally, nebulized, and even intramuscularly. I actually left off of there. When we talk about glutathione and giving you some of the precursors to glutathione, we know that cysteine is one of the amino acids that are part of or that are required to make glutathione. So supplemental cysteine in the form of whey or N-acetylcysteine is effective. And then there's substantial variation, but about 1,000 milligrams a day of NAC will substantially increase the glutathione in most patients. All right, let's move into a couple other cases now. Let's talk about cardiovascular risk reduction. And this is really what I want to focus on, and I'm going to move through here quickly. This is my first time doing this talk, so I actually probably made more slides than I needed, but I want to talk about cardiovascular risk reduction. And so the first case is a guy who's a 74-year-old guy who presented to me. He had seen another cardiologist, I think he had a family history of heart disease, did not have any known history of heart disease himself. But I think the key things I want to take from this is that he had a history of an elevated homocysteine level of about 23. For those of you who are familiar with homocysteine, 23 is pretty darn high for a homocysteine level. And this is actually the note from his previous cardiologist who had seen him. So I actually put this in here because I think it's important. They note the homocysteine and as we kind of move forward, they set him up for a stress test. We're going to do our typical workup. Okay, we're going to just get a stress test and an echocardiogram. And then at the end here, it says homocysteine is elevated. Now, I find that problematic, right? The guy, if we're looking for risk for heart disease, then homocysteine is elevated. Well, why is it elevated? And we know there's so many things we could do about that elevated homocysteine, but homocysteine is elevated. That's what's written. Okay. So he ends up getting a coronary calcium score, and the coronary calcium score is fairly elevated. 482 would be a suggestion of kind of some underlying coronary disease. And then he ended up getting a coronary CTA, which did reveal mild disease in the left main coronary artery. He had kind of mild to moderate disease in the LAD, mild disease in the left circumflex and the right coronary artery. So no severe stenoses, but certainly disease that we want to make sure we prevent from progressing. So here is where I think that it's important that if you all are not using some type of advanced lipid protocol or advanced lipid panel, I mean, I think it is imperative that we get past using just your regular lipid panel. A cholesterol, LDL, HDL, triglyceride, it really doesn't, for me in my practice, this is my personal opinion, it doesn't help me much at all, because I mean, there are many patients who have cholesterols of 270 that don't have any heart disease and their risk is low. What we need to know is the size of their particles, the particle number, and inflammation markers, and other risk markers like LP(a). I want to comment on LP(a) for you. Those of you who don't know about lipoprotein(a), it's a very, very important marker that we should always look for. It's an independent risk factor for coronary artery disease and an independent risk factor for underlying aortic stenosis. So calcific aortic stenosis develops in people with elevated LPA levels at a much higher rate, and I'll show you some statistics on that shortly. So again, when he got these labs with me, his homocysteine was elevated. Fortunately, it wasn't 23. 15 is still a bit elevated, but it was certainly coming down. CRP a little bit elevated, and myeloperoxidase, which is another inflammatory marker. This is a marker from white blood cells of potentially underlying active plaque. So certainly when myeloperoxidase is high, I am a bit concerned that we need to calm down the vessel wall. So these things now put him at higher risk, and we can address all of these things. So just a little bit about homocysteine, and this was published by Mark Houston, I guess, many years ago. But we know that homocysteine is a risk for underlying heart disease, stroke, and with that number of 23 or 24 that he had about a 12 times risk higher of having some type of cardiovascular event than the normal population where it was normal. And then even at 15, he has about a 4 times the risk of a cardiovascular event with the homocysteine being elevated. So why we just look at homocysteine and say it's elevated and not address how we can lower it, it just befuddles me. More importantly, this use of lipoprotein, and this is actually from the Journal of Clinical Lipidology on LP(a). We now know that it is very important, and it is a very important marker. 3 to 4 times higher chance of myocardial infarction, 3-fold higher chance of valvular aortic stenosis, 5-fold chance of higher chance of coronary artery stenosis. So if you see an elevated LP(a), we need to figure out what can we do about it. And I put this in this talk because this is a talk about micronutrients. And I'm going to show you shortly what micronutrient in particular has been shown to lower LP(a) more than anything else out there. Just a little bit more about LP(a). 1 in 14 heart attacks and 1 in 7 cases of aortic valve disease are due to LP(a). 1 in 5 individuals have high LP(a) are at increased risk of cardiovascular disease. It is highly heritable. Most of the LP(a) elevation is genetic in nature. And screening and therapies could prevent 1 in 3 heart attacks and 1 in 2 cases of aortic valve disease. So what do we know about what's that magic molecule? What can we do about LP(a)? Many of you know who Linus Pauling is, and Linus Pauling did a lot of work with his student Rath, and they actually did many studies looking at not only guinea pigs, but they actually did human studies as well, showing that higher doses of vitamin C lower LP(a). Now, I don't, again, why and how this has not become something that is standard of care. And I'm going to leave it to you guys to think about that and figure out why. I'm not going to belabor that point, but I can tell you that there are lots of studies out there that describe how and why, and there's lots of science how LP(a) and vitamin C are linked. But I will tell you that high dose vitamin C can be used to lower LP(a). Niacin can be used to lower LP(a). Estradiol in women and testosterone in men can be used to lower LP(a). So this is this gentleman's micronutrient panel, all right? So the same gentleman who has this moderate disease, kind of mild to moderate disease, elevated homocysteine, this is his micronutrient panel. So cellular B2 is low, zinc, inositol, which is B8, is low, arginine serum is low, CoQ10 is low. So we know that CoQ10 is really integral in the function of the mitochondria and as an antioxidant, right? So all of these things from a cardiovascular perspective, we know that B2 is very important as well in the methylation process. So as we move through, his micronutrient panel, this becomes very, very interesting. This panel is fairly long. I'm gonna flip through these slowly, but I want you guys to pay attention to one thing, okay? I want you to look at each of these micronutrients in the extracellular component, and then look at where the intracellular components are for most of the micronutrients, all right? So B1, B2, B3, B6, B12 is okay, but B5, vitamin C, D3, E, K1, calcium, manganese, folate, zinc, copper, inositol, choline. So I'm making a point here. If you look at the extracellular component versus the intracellular component of most of his micronutrients, what does that mean? So when I have so many of these, this tells me that his cell membrane, there are issues with his cell membrane and getting nutrients across into the cell because of cell membrane issues. And we're going to talk about that. That becomes very, very relevant when I talk to you about some of the therapies we have. And that will have to be another lecture probably, but when I talk to you about some of the therapies we have to improve the cell membrane function. So what I did for him, basically, he had a lot of further workup looking at risk factors for coronary disease. He had a wheat zoomer, which is going to look for intestinal permeability, gut zoomer. He had a cardiac genetic panel, heavy metals and environmental toxins. But I started him on a B complex, IV. I started him on vitamin C in his IVs, magnesium and glutathione twice monthly. I began Plaquex twice weekly for a total of 30 treatments. I'm going to talk about Plaquex. This is a lecture into itself. But that is the molecule that can improve the lipid bilayer, and it's likely why he's not absorbing most of these nutrients into the intracellular component. Oral CoQ10, B complex, omega-3, magnesium, we started him on, and he was an ApoE3/4. Again, we could talk about this for quite some time, which we know that this increases his risk of heart disease and other neurocognitive issues and detoxification, particularly if he's eating diets that's higher in saturated fat. But so this is kind of what we did for him. I'm going to move into a second case really quickly. 73-year-old guy, moderate mitral insufficiency, some occasional chest burning. He did notice that he had some burning in his chest after he ate and went for a walk. He had a stress test that was normal the year prior. So, you know, it was kind of one of those things. I was like, well, I don't know if this is cardiac or not cardiac. He had some basic lab work done. And just looking at this number, his cholesterol is a little bit high, quote unquote, right? So, okay, I'm a little bit concerned. And then the advanced lipid panel, we look at that. And again, he had some small dense particles that were elevated, but more importantly, that same lipoprotein little a, okay? Lipoprotein little a was significantly elevated. Lipoprotein phospholipase A2, okay? Again, elevated, and this is an inflammatory marker in the vessel wall. So now I look at this panel, I said, he's a fairly high risk guy, and topping it off, his homocysteine was also high. So I said, you know, we probably should do a coronary CTA just to kind of see what's going on, because I don't like the risk factor profile that I see. So lo and behold, he gets a CTA and he has a calcified plaque and total coronary occlusion of the LAD, a 50 to 69% stenosis in the left main coronary artery, and then some other residual disease, 25 to 49% blockage stenosis in the right coronary artery. So minimal symptoms with and still exercising, but his risk profile was so high, I said, I don't like what I'm seeing, and this is where we were left. Now, this guy, okay, what do we do here, okay? With a left main lesion, you know, no matter what, I don't care what kind of magic I think I have up my sleeve. I sent him for cardiac cath. We ended up doing a PCI and opening up the distal left main into the LAD, and he's done wonderfully. I have placed him on Plaquex because at the end of the day, he still has underlying coronary disease, and we want to make sure we prevent progression and even potentially cause some plaque regression. But this was one of those things where you have to look at the risk benefit of this therapeutic approach, and it's kind of a combined approach of using, you know, our technology and using the procedures, and now completing our therapy with IV nutrient therapy with the B complex and vitamin C, magnesium, glutathione, similar to the other gentleman that we just presented. And then lastly, this is another case that I want to briefly kind of go through. 51-year-old guy, anxiety, atypical left lower quadrant pain, no other cardiac risk factors. He exercises regularly. He was seen by a cardiologist a year ago and everything was okay. Everything looked good. This is what he shows up to me with, okay? And this is where I'm gonna go back to that panel. I told you guys, I don't think a cholesterol panel like this does me a whole lot of good, all right? Cholesterol panel, HDL is a little low, but doesn't look entirely too bad. When we look at our panels and when we look at our ASCVD risk estimator, and we put in all of his statistics, and he has about a 4.6% risk, so low risk of a 10-year coronary event. So he's a low risk guy. But as I said, I never get just a regular lipid panel. When you look at his advanced lipid panel, his particle number was elevated, his small dense particles were extremely elevated, okay? The lipoprotein phospholipase A2, again, inflammation in the vessel wall, again, it's extremely elevated. Homocysteine, elevated. Oxidized LDL, elevated. So again, this makes me a little bit, the risk profile is there again. We need to look a little bit further. So I sent him for a coronary calcium score initially, and his coronary calcium score was 282. Again, that's elevated, and I gave him the option, well, we can continue just to treat you, or if we really want to know how significant, if you have significant stenosis, and if it's a 10% versus, 80% stenosis, we should do a CTA. Whoops, I forgot one other important part, sorry. This is another part of the reason. He's an ApoE4/4. Again, not a lot of time to talk about that. I could say a lot about ApoE status. We just talked about it briefly, but again, putting him at higher risk for underlying coronary disease. Coronary calcium score ended up being 280. We got a CTA, and he had sequential 50 to 70% stenosis in the LAD, as well as the right coronary had moderate disease in it as well. We decided to treat him more conservatively, and it turns out he ended up having a little bit more. His workup showed heavy metal toxicity with 4 or 5 different heavy metals: arsenic, cadmium, barium, cesium. Interestingly, he came to me after his wife initially saw me. His wife had seen me for, she had metastatic breast cancer, and she ended up having heavy metal toxicity with the exact same heavy metals. Their panel was exactly the same. So, I mean, and I don't think there's a question in my mind. I think the cancer had a lot to do with the heavy metal toxicity. It turns out that they had a house up in Maine that they were having a lot of water problems with. They knew about it. They couldn't sell the house. And so they were still dealing with all these heavy metal issues. So what we did for him is we actually started him on chelation therapy with the Plaquex therapy, along with all of the other same oral therapy that we talked about before. So how do we use IV nutrient therapy to help us with these type of situations? Obviously, we know we live in a world where a lot of gut absorption issues are a problem. So the IV nutrient therapy is a great way to actually get these nutrients in, or to get the effects that we're looking for. So the primary IV formulations or the micronutrients that we're using are glutathione, the B vitamins. Again, I can't emphasize enough the importance of the B vitamins, as you can see throughout the rest of that presentation. Vitamin C, amino acids, and other minerals like magnesium, calcium, zinc. The IV administration of nutrients achieves higher serum concentrations than oral or IM. We know that that vitamin C can only reach a maximum amount, no matter how much we give orally. There's a maximal concentration that we can reach in the serum, whereas the serum concentration can be much higher with the IV formulation. Intracellular nutrient concentration is necessary. A higher intracellular nutrient concentration is necessary sometimes. And as you saw in the one gentleman where the micronutrients were not getting into the cell, then and we need to get that intracellularly. So by absorbing more, there's a higher potential that we could get more into the cell with a higher absorption in general with the IV formulations. Just for the sake of time, I want to kind of get through some of the Liquivida micronutrients. We talked a lot about the B vitamins, right? So we got thiamine B1, riboflavin B2, and B6, B3, B5. So all of the B vitamins are in all of these particular Liquivida drips. And so when we talk about methylation and we talk about elevated homocysteine, I think that invariably any of these drips with the B vitamins are going to be helpful. Glutathione and vitamin C. Obviously, if you have a lot of oxidative stress, rust buildup, then these are going to be the fountain of youth. I would say probably 80% of the drips that I do in my office are fountain of youth, just for the glutathione and the vitamin C. And then we have the vitamin C, the MIC-B12, methylcobalamin, and B complex that can be given by themselves as well. Again, for the sake of time, Liquivida has a wonderful handout of all of these conditions: fatigue, depression, and talks about the specific role of specific micronutrients and what drips that can be used to help with that. So I would encourage you guys to request that from your Liquivida representatives. That would be very helpful. Depression, immune boosting, heart disease we talked about, inflammation. And then lastly, I'm going to touch on this, and I realize we're running really short on time. So I want to say this because plaque is such an important part of cardiovascular risk reduction, but it's also an important part of mitochondrial health. When we talk about the cell membrane, that is your cell membrane. As we get older, and I'll show you some pictures. Well, what I'll do is let me just kind of get through this. We use plaque as a way to improve cholesterol resorption from the artery because it improves reverse cholesterol transport. That's the mechanism that it works. It improves the cellular efficiency. What is it? It's a soy-based lecithin product, 1,2-diallyl phosphatidylcholine. There are lots of different types of phosphatidylcholine out there. You really want to make sure you stick with the branded formulation and not another compounded one, because they're made with different, these side chains are different, unless it's plaque X. And what it basically does is it improves this cell membrane. When we're born, 90% of our cell membrane is polyenolphosphatidylcholine, PPC. As we get older, we lose down to about 10%. And these phospholipids develop these saturated fatty acids, tails, as opposed to unsaturated fatty acids. And so that affects the membrane cell fluidity, that affects the enzyme function. When that gentleman who we saw that all of the micronutrients were low intracellularly, that's likely because of the cell membrane was not functioning efficiently. So the plaque X not only is going to help lower his cholesterol and get cholesterol out by increasing reverse cholesterol transport, but it's going to improve the membrane function so that these micronutrients can now get into the cell much more efficiently as well. Here's a wonderful review article. This is a pretty long article, but if you guys, if you want to know more about how PPC phosphatidylcholine works, this is a wonderful review article here, and it talks about it from a neurocognitive perspective and a mitochondrial health perspective. It talks about it from a cardiovascular perspective. So I would encourage you guys to kind of find this article. And it's a fairly, it's 2014, if I recall, 13, but it's just a wealth of information. This was the first article that I read and kind of got me interested in using the product. And now I just want to show you kind of, this is one of my guys who completed a 20 sessions of the plaque X. He's a guy who had about a 70% stenosis in the right, the LAD. He didn't want to have any type of procedure. So what I did is we did the plaque X and all the other therapies that we mentioned. And one of the things I want to show you guys is, if you look at his numbers this is between May and December, all right? His total cholesterol was the same, okay? But the interesting part here is if you look at his HDL, when have you seen an HDL climb 51%? In 6 months, he went from 68 to 103. Plaque X works by increasing reverse cholesterol transport. It increases HDL. Now, we know that not all HDL is good HDL, right? It's the large buoyant HDL molecules that are the HDL particles that actually take cholesterol esters out of the body, out of the artery, theoretically. If you look down here at the large buoyant HDL molecules, an 83% increase in his large buoyant HDL molecules in 6 months, right? So we're just waiting on, he was the first person that I kind of got started on this whole process. He's getting his repeat CT scan next week. I was hoping to have that result to show you guys. I'm not sure what I'm going to expect, but this is the kind of thing that I want to follow long term. There's a lot of European data on phosphatidylcholine and plaque regression, but I just want you guys to be aware of it, and I'm probably going to be happy to talk about that at some other point. But I thank you all for your time. I know that was a lot of information. I could talk about a lot of things for a long time, but thank you guys again for all of your attention. Here's how you can reach me if you guys have any questions. I really enjoyed it. I will be around for a couple of questions if you guys are interested.
All right, Dr. Davis, thank you so much for all of that information, and especially those case studies. I know that so many of us will find that helpful. And we did have a few questions. So first of all, a lot of people are asking if we will have a copy of the PowerPoint and like any notes on certain abbreviations. So if Dr. Davis is able to give that to us afterwards, we will make sure to have that along with the recording.
Yep, I'll get it to you. My pleasure.
Perfect.
My pleasure.
And then we also had a few questions about if it is going to be recorded. I know some folks came in late. So yes, it will be recorded and it can be found on our YouTube channel, as well as our Vibrant providers will get an email with this recording in 3 to 5 business days. Okay. So someone is asking, what is SAMe again?
So SAMe is S-adenomethionine. So it is actually a product that is part of the methylation cycle. That is what we call the universal methyl donor. So when we go through this whole process of methylation, SAMe is that molecule that one carbon comes from to be methylated. So I don't know how, without going into a long explanation of what methylation is, it's kind of hard to explain, but SAMe is what we consider the universal methyl donor. It's made from methionine. It's in that process of converting homocysteine to methionine. Then SAMe is made, and then SAMe goes off and does lots of stuff.
Perfect. Okay, and then someone else is asking, is it safe to administer a massage while massaging multiple essential oils onto the body while allowing an IV cocktail to infuse?
Yeah, I don't see why. I mean, I can't imagine that. Why not? I would say yes. I don't think that would be an issue.
Okay, perfect. And then right now, that is all the questions that we have. If anyone has any more, they can go ahead and type them in before we wrap up. Oh, here we go. We do have a few more. So can you comment on glutathione admin and sulfa allergy as well as asthmatic patients? Apparently there is contraindication.
Yeah. You know, that's a tough one. You know, we actually, there in the Liquivida, we actually talk about asthma or COPD being a contraindication to the glutathione, but there is a lot of, and I think, from my literature search, and I did this because there's other literature out there that shows the benefit of glutathione in those COPD patients. And what I found, there was one case or two cases that there was an older gentleman, a case study that actually had pretty precipitous kind of reaction after the glutathione. And so I honestly, do it? I use glutathione in my COPD patients. I think maybe it's a difference between COPD and asthma. In the asthma patients, maybe it's with more bronchospastic disease, it may be contraindicated. And I think it's even then a relative contraindication. I don't use it for asthma. I do use it for COPD. That's kind of my answer.
Perfect. And then which micronutrients can I give to my clients starting a chemo pill? Can I still give glutathione?
During
chemotherapy?
Yeah, well, I think that's a tough question because the timing of it, I think, is going to be tough. I mean, if you're doing chemotherapy and the goal is to create an oxidative state to kill off the cancer cells, then giving glutathione immediately may be somewhat counterproductive. And I'm not an oncologist. I'm kind of speaking just in general terms, just thinking through. So the timing of it, I think, would be important. Because if you're trying to, again, if the whole goal is to create more reactive oxygen species and stress the cells and kill those cells, then giving glutathione may be counterproductive immediately. Now, that once they've gone through the therapy as part of a recuperation strategy, I mean, I think that would be a great strategy. So I mean, maybe an oncologist may be a better person to ask that question, but I'm really just speaking theoretically right now.
Okay, great. And then the last one that we'll answer for now is, how can I, as a Liquivida affiliate, do the micronutrient testing?
I think what we hope to do, and I mean, you get me, every one of you all can set up accounts with Vibrant. The micronutrient testing Vibrant is by far, in my opinion, the best micronutrient test that's out there because of the intracellular and extracellular components, as you saw with the presentation. And so just setting up an account with Vibrant would be the way to do it.
All right, great. Well, thank you so much again, Dr. Davis, for that incredible presentation, as well as taking your time to answer some of these questions.
All right, my pleasure. You guys have a wonderful night, and thank you guys for attending.
Thank you so much. Take care, everyone.